Well, in my opinion, it's really important to go back to the basics. So when I see patients with any pain condition for medico-legal case, in advance of that, we will send them questionnaires. We'll ask them to fill those out a week or two before they come to see me. When I see them face to face, or these days by remote consultation, the most important thing is to do a detailed examination as far as you can. At the moment, we're having to do, as you can imagine, remote consultations, and all myself and my colleagues are getting quite adept at examining patients via camera and getting them to do various things and examine themselves with cotton wool and pinprick tests and all of that sort of thing. The Budapest criteria, as I say, realistically, this is the clincher. If you can prove for or against this, then you've got a reasonably strong case. The other thing is investigations. As we said before, that's not a deal breaker, but it is helpful for the case if you have positive findings. And then the next thing really is, obviously, as in all cases and in all pain cases, it's properly looking through the records. So with the medical records, realistically, it's looking for consistent patterns. And in CRPS, the sorts of things you're going to see are patient has an injury, is not getting better. You may start to see they're seeing physios, they're seeing doctors. It says, oh, it's red, it's hypersensitive, patient can't move it. Patient describes lots of pain, 2 months, 3 months, 4 months, whatever, since the accident, not getting any better. They may get referred to orthopedics, to pain doctors, and at some point, somebody may do a Budapest criteria on them, or, as I find in a lot of cases, they percolate all the way down 3 to 5 years later when they have these medical legal reports, when is often the first time the actual Budapest is properly applied. But if you go through the records of these patients, generally speaking, you will find a pattern which points in the direction of CRPS. And certainly in pain clinics, you may find that patients are on the medications that we discussed, or they undergo the blocks and the procedures that we've discussed, and that sort of thing. The next thing really is function. Now, this really depends on what the patient tells you, what they fill in their questionnaires, and obviously whether or not that marries up with their witness statement. And in a number of these cases, certainly surveillance can be key one way or the other, to see, obviously, whether or not the surveillance footage that you are looking at marries up with the function that the patient says they can or can't do. So these are some of the Budapest criteria. What I tend to do with the CRPS patients is, as I said, when I see them, I'll examine them, but also I will go through this checklist formally, and that's really just to keep it absolutely straight and clear in my mind. I can go through each of the as you'll see of any of one of these, I'll go through the symptom checklist and I'll go down that list. I'll then go through the signs checklist. I'll do a general examination of them anyway, and I'll look through it. Here's some interesting one on the first one. These are fairly random, but I've put here notes. Tick, fulfills the Budapest criteria for diagnosis of CRPS. However, pain better described as mixed, nociceptive and neuropathic pain based on the history and examination findings. So that would be a good example where a patient may present with CRPS. They may be positive for the Budapest criteria, so ostensibly they have CRPS, but actually when you look at them, you read through their notes, you examine them and you think about it, you think, well, yes, they do have those criteria, but actually their condition may be better explained by another diagnosis.